Let me tell you, I'm going to talk about a subject that for many years, for many centuries, for millennia, has been considered taboo. I have a small book at home that I read myself to sleep at night called Menstruation. And it elicits all the social, emotional, practical problems associated with regular menstruation, but any vaginal bleeding that has taken place, particularly in cultures, even today, that we would consider sophisticated. So the problem is we're going to talk about abnormal bleeding, and then we're going to talk about unscheduled bleeding. Both of these topics are very rarely mentioned in polite society and may also be difficult for you in your practice. So these are my financial disclosures. I do an awful lot of clinical trials, and so I have a fair number of commercial interests that have paid me for doing clinical trial work. So what we're going to talk about first is perimenopausal bleeding. Of course, perimenopause can be anywhere up to 5 years before the last normal menstrual cycle, and therefore the woman enters menstruation. But you can easily divide it into several different categories, and I've done it here for you easily. The regular cycles with heavy menstrual bleeding are either uterine myomas or unknown etiology. And so the problem is if you have a patient with heavy menstrual bleeding who has uterine myomas, you have an association. And I stress association because I am unable to find a clear-cut fibroid myoma cause of heavy menstrual bleeding. I say unknown because it could be an endometrial polyp, a physical problem that we see associated with it. But sometimes, in most instances, we don't find a major problem, although as clinicians, if we can identify a problem, we'll assign it to a category of associated with, in some cases of pelvic endometriosis. Some adenomyosis are also associated with heavy menstrual bleeding. In the perimenopausal transition, as been shown on several occasions, menstrual periods can become irregular, or they lengthen in the interval, but they are sometimes associated with heavy menstrual bleeding or normal withdrawal bleeding. And I believe this is part of the transition between normal menstruation and postmenopause, and is related to anovulation. Whether you believe the ovary is unresponsive or there's been a change in episodic secretion of gonadotropins from the pituitary as the cause, women become anovulatory immediately preceding the last menstrual period. And then there are irregular intervals with or without a change in the bleeding pattern that should really alert the clinician to the possibility of a neoplasia. And the argument throughout this talk between ages 35 to 50 and 55 and above is how high is your index of suspicion that you're dealing with an unsuspected cancer. And so the American Congress of Obstetrics and Gynecology talks about doing endometrial biopsy for irregular, unexpected alterations in menstrual blood loss or duration of menstruation. And I cannot argue with them, suffice it to say that sometimes it appears to be physiologic, like the woman who is entering the perimenopausal transition. Sometimes the actual diagnosis is uterine fibroids, and certainly that's a possibility. So as you know, there has been a move recently, sponsored by a group through FIGO and other organizations, to change the way we diagnose abnormal uterine bleeding. So the plea has been to get away from the Greek terms menorrhagia and metrorrhagia as being not identifiable, and to use terms like abnormal or normal for what we're dealing with. So under the abnormal uterine bleeding, you can have heavy menstrual bleeding or intermenstrual bleeding, unscheduled bleeding. And under the POM-COIN, the POM stands for polyps, adenomyosis, leiomyoma, and are a malignancy with hypertension. So that's heavy menstrual bleeding. Under the intermenstrual bleeding, you can have, and heavy menstrual bleeding can have coagulopathy and ovulatory dysfunction, as you can see. But then there's an intermenstrual bleeding category that is called endometrial. And I'm going to tell you about this only from a look at it standpoint, because I cannot tell you why it occurs and how to treat it. But I can assure you that it is related to the use of a progestin. This progestin is creating an abnormal endometrium, probably involving the microvascular system in the endometrium. Unscheduled bleeding occurs. I have no reason to tell you how it does. I am frustrated with trying to figure out why it does, and I can only tell you the treatment is often empirical. And then there's the estrogenic cause of unopposed estrogen that causes unscheduled irregular bleeding. And then another category, at least in this categorical sense, is called not yet classified. So heavy menstrual bleeding, and let me not talk about surgical treatments. Let me tell you the problem with heavy menstrual bleeding. I call it an orphan disease. It doesn't kill anybody. It occurs monthly. It is self-limited to no more than 3 or 4 days, and it is easily cured by doing a hysterectomy. Ergo, it is an orphan disease. So these are the medical treatments that are approved in boldface and have been used in non-boldface. The levonorgestrel intrauterine system, tranexamic acid, which is an antifibrinolytic, a combination oral hormonal contraceptives. What have also been used and shown to be effective in inhibiting heavy menstrual bleeding are progesterone receptor modulators, such as ulipristal acetate. Progestins, either oral or injectable, which the Cochrane analysis says has no benefit but is still in vogue, being used either cyclically or continuously. And non-steroidal anti-inflammatory agents, which may have a small modicum of improvement. At least it is worth trying in some women in relatively high doses. So the levonorgestrel intrauterine system is a very effective method of reducing heavy menstrual bleeding. It actually inhibits normal menstrual cycles, but at the same time increases the potential for unscheduled irregular bleeding, which again is a progestin-related effect. So it prevents cyclic shedding. It alters, and I will show you some data, the plasminogen activator system. It reduces endometrial thickness, opposing and reducing estrogen receptors in the endometrium. And therefore, it converts the endometrium either to a secretory in the initial use or to an atrophic phase with continued use due to the fact that there's no underlying estrogenic stimulus. And it changes from a scheduled to an unscheduled spotting or bleeding as it is used. So the spotting and bleeding, which will come back whether it's premenopausal, postmenopausal, related to a contraceptive, related to hormone replacement therapy, has to do with an alteration in the microvessels underlying the lining of the surface lining of the uterus. That's the surface lining of the uterus in slightly yellow. Underneath them is this extensive capillary plexus of microvessels that are barely able to get a red blood cell through. So they're usually about 15 microns in diameter, shown here in this cartoon as red and blue. In order for you or the patient to see that they're bleeding, this vessel must break down. It must disrupt. It must break open. And in general, the amount of blood lost from that blood vessel is contained due to this epithelial lining at the top. And so ultimately, you have to break down the epithelial lining in order for the blood to egress into the uterine cavity. On top of that, during normal menstruation, and for you and I or the patient to see menstrual blood, this blood has to remain liquid. There are huge amounts of proteases and metalloproteinases in menstrual blood, because if the blood were to clot, it could not get out of the uterine cavity via the cervix. So it must remain in a quasi-liquid form. So you have to see that the breakdown of the blood vessel could potentially be to a collagenase increase. The rupture of the epithelium could be, again, collagenase, breaking down collagen ground substance. And then these proteases are also keeping the blood liquid, allowing it to egress, and we see it. So when you disrupt the blood vessel, the immediate response is that there is a release of von Willebrand factor from the endothelial cell that binds to the basal membrane and changes it and begins to attract through a binding protein called GP3 to circulating platelets. And these platelets come in and form a platelet plug. And then the platelet plug has deposited in it fibrin. And so this fibrin keeps this vessel from bleeding. So the bleeding is, the platelet plug, et cetera, is immediate. And most bleeding, if you cut yourself, will stop within 4 minutes. The trick is that you do not want this blood clot to keep running back up the blood vessel. So you immediately begin lysing the fibrin, breaking down the clot, in order that that blood vessel may ultimately be repaired and be patent and be functional in the future. To take down the clot, you need plasmin, which is the fibrinolytic factor that is most important. And so there are plasminogen activators, tissue and urokinase. Tissue plasminogen activator is the principal one, shown here. And it is controlled by its major inhibitor, plasminogen activator inhibitor 1. But tissue plasminogen activator converts plasminogen to plasmin. And this plasmin starts breaking down the fibrin in that clot immediately, almost at the time the clot is forming. So you get this dynamic reaction. And in actual fact, as we sit here, this type of clotting fibrinolytic activity is taking place, and that's why we do not have a clot. So when you upset the balance, you clot, is what it boils down to. We know that using levonorgestrel in vitro, that we can reduce tissue plasminogen activator. And these are data published by a colleague of mine, Tarita Pakrashi. And what she has shown is that we do not change the inhibitor of the tissue plasminogen activator inhibitor 1, nor does progesterone. As compared to levonorgestrel, they have no effect compared to control. But the levonorgestrel actually reduces tissue plasminogen activator. When you do that, you stop the fibrinolytic activity because you're maintaining the plasminogen activator inhibitor level, and you have less biologically active plasminogen converted to plasmin. We have found that flutamide, an androgen receptor blocker, actually blocks this effect of levonorgestrel in the endothelial cell. Now, you would think levonorgestrel should act through the progesterone receptor, but I showed you progesterone had no effect on this changing of the tissue plasminogen activator. And what we have now shown is that there is this degree of androgen receptor within the endothelial cell. This is the first report of androgen receptors being present in endometrial microvascular endothelial cells. Second, therefore, we believe that one of the mechanisms to stop the bleeding, the unscheduled bleeding and the heavy menstrual bleeding, is by reducing the amount of tissue plasminogen activator physiologically. Secondly, tranexamic acid actually also works through this mechanism, because what it does is it actually inhibits the molecule plasminogen and keeps it from being converted to plasmin. And so it is antifibrinolytic because it binds to this one receptor amino acid in plasminogen, and it won't come through. And therefore, you have more plasminogen activator functionally keeping the clot forming. And tranexamic acid given at the time of menstruation will reduce the amount of excessive blood loss by 50% or greater in most women, whether or not they have uterine fibroids or not. And so it has been used in uterine fibroids effectively. However, when you go back and look at these data, only about 50 to 60% of the women really normalize their blood loss and get it below 80 milliliters per ml per cycle. The reason for this is unknown, but I can assure you it is multifactorial. It is not only the plasminogen system, there are other systems, to the point that sometimes I go to sleep so I don't have to stay up all night thinking about it, I can assure you. Birth control pills also work, but in the United States, the only one that has this approval by the FDA is estradiol valerate dienogest. But essentially, all of them work. They all, when you put a woman on a birth control pill who is normal, will reduce the amount of blood loss. Everybody says tritely, this is due to the fact that the endometrium gets thinner. Yes, it does. Blood loss with menstruation is related to the volume of blood that is being lost. That makes sense. But there is compelling evidence that you are inhibiting the COX-2, cyclooxygenase 2 enzyme in the endometrium in women on combination birth control pills. And COX-2 increases prostaglandin, and prostaglandin and inflammatory activity can enhance the collagenases, the metalloproteinases, et cetera, at the time of menstruation. And now, the etiology of menstruation has shifted from what we taught you classically as a arterial constriction and opening again, a classic reperfusion injury, to an inflammatory reaction brought about by the ingress of leukocytes into the endometrium as progesterone levels fall and menstruation is initiated. So you can see here a significant reduction in blood loss in this woman, this group of women. Whether or not you use estradiol valerate and dienogest, I personally believe, without evidence, that all combination oral contraceptives are effective. These are the data from ulipristal acetate, published in the New England Journal a couple of years ago by Dr. Donez, basically showing you that in heavy menstrual bleeders with fibroids, you start them on 5 or 10 milligrams a day of this continuously. After that first period, when you start them on day 3 to 5 of bleeding, they don't bleed again. Continuous administration. Ulipristal acetate is a progesterone receptor modulator. There have been other progesterone receptor modulators that show the same thing. I just forgot the AbbVie company name, but that product was never brought forward other than the fact to show that you inhibit bleeding. And so, that column, right here, is the 80% amenorrhea rate in these women over a 3 to 6 month period of time using this drug. So let me come back in the latter part of unscheduled intermenstrual bleeding. I'm going to use both premenstrual birth control pill data, postmenstrual hormone replacement data, to show you what I believe are the multiplicity of factors that are involved in causing this unscheduled intermenstrual bleeding. There is compelling evidence from Charles Lockwood that local inflammation or damaged microvessels is the initiator. And when you damage this blood vessel and you get this rupture and you have anoxia or hypoxia, you increase vascular endothelial growth factor, which is a potent angiogenic factor. You can also, with inflammation, induce metalloproteinases. You can cause dissolution of collagen, and that can cause the rupture of the blood vessel as these metalloproteinases increase. You can dissolve the uterine lining epithelium with these collagenases, and you get an altered hemostasis, possibly in terms of the plasminogen activator system, where you see that the blood has to stay liquid in order to extrude itself from the uterine cavity. And then ultimately, because of the VEGF and vascular endothelial growth factor and possibly other angiogenic factors such as urokinase plasminogen activator, you get altered angiogenesis. And I'm going to try and show you a hypothesis that as you increase angiogenesis, you cause a distortion and an abnormality in the vessel due to a lack of what are known as periocytes. So this simple cartoon is to only demonstrate to you the multiplicity of factors that occur as we withdraw progesterone in a normal menstrual cycle. And essentially, when you use a orally active progestin, as Dr. Lobo pointed out, you're getting up and down, peaks and valleys. And there may be other initiating events that I'm not aware of that can cause these changes. Progesterone withdrawal, increased influx of white blood cells, hypoxia, increase in VEGF, increase in metalloproteinases, loss of collagen infrastructure, dissolution of the collagen, breakdown of the blood vessel, breakdown of the epithelial lining of the uterus. Periocytes during angiogenesis are recruited very much at the tip of the new blood vessel that's forming. They cover the luminal gaps between these epithelial cells, like putting duct tape around a pipe. So you see a decreased number of periocytes in levonorgestrel users and in women who are postmenopausal hormone therapy users with medroxyprogesterone acetate. The data are mixed. Some say yes, some say no. But what I believe is without this periocyte around this blood vessel, you get a bulging of this blood vessel, a sinusoidal dilatation, which has been shown, and it alters this morphology, it alters the integrity, and it's classic with Martha Hickey pointing out that when they went in with a hysteroscope and increased the intrauterine pressure with saline infusion and then dropped it in Norplant or levonorgestrel users, you could see little spurts of blood from fragile blood vessels coming out through the endometrial lining. And so without the periocyte, shown here in the blue, wrapping itself around this blood vessel, you have lost the integrity of this vessel. You've made it easier to rupture. You are potentially arguing that it is a possibility as the cause. And I can tell you that progestins alter angiotensin II, which is really an apoptotic factor for these periocytes. So let me come back to drospirenone, which I appreciate Dr. Fenton bringing in this problem early on. This is a progestin that has anti-mineral corticoid activity and anti-aldosterone activity at the endometrium. And this is a study using progestin only as a progestin-only pill in women and on a 24 to 4-day cyclic interval, 24 days on, 4 days off. And I want to point out to you that there are 4 different bleeding spotting patterns in this group of women. First off, there's the pattern that everybody would like to have. Upper left-hand corner, 45% of these women. They were tolerable patterns, upper right hand, lower left hand, in about 42% of the women, which were unscheduled bleeding, but not enough to say, I want to quit the pill. And they occurred very rapidly. As you can see, these are really cycle day, second cycle at the beginning of every one of them. And within a week of going back on the pill, these women were bleeding again. There is a mid-cycle blip that I think is due to follicular atresia, generally shown about day 10 or 12, usually about out here, and it occurs. And then there is the problem patient that will never let you alone. 13% of these women had a chaotic bleeding pattern. From the get-go, they bled. Whether that was in the second cycle, the 6th cycle, or the 13th cycle, they did the same thing throughout this study. The same can be said. Once they establish the pattern, they have the pattern forever. And so once they say to you, once you know that they are bleeding erratically, put them on something else. Second or third cycle, they know it. And so this is the demonstration again of showing by patient clusters this mid-cycle increase that is obvious here and again here. What we do know when we looked at these data, very interestingly enough, is that the group cluster 1 that didn't have a lot of irregular bleeding or spotting, the upper left-hand corner, was associated with increased systolic and diastolic blood pressure. The systolic was 130, the diastolic was 85, and they were overweight. So I would like to ask you all, who are all trained experts in your field, that after this presentation and meeting, if you will come up to me and tell me how the progestin can at the same time initiate bleeding, but at sometimes in hypertensive obese women can make them not bleed. I cannot figure that out. I've thought about the mineralocorticoid receptor, the glucocorticoid receptor, and of course the androgen receptor. I have no answer. Clusters 2 and 3 I showed you. Scheduled irregular bleeding, reasonably acceptable. Cluster 4 was the worst. Do something else with them. In menopausal hormone therapy, am I okay, Amos, for time? I'm okay? In menopausal hormone therapy, we know that unscheduled bleeding and spotting with continuous combined therapy occurs, at least 40% with estrogen plus progestin. I've shown you that it has to be a vascular dysfunction. This blood vessel has to break down and the lining has to be dissolved. You can reduce the incidence by reducing the estrogen or estrogen plus progestin dose. You can use estrogen plus a selective estrogen receptor modulator, as Dr. Lobo showed you with basidoxifene. The possible mechanisms: altered angiogenesis, changes in periocytes, increased metalloproteinases, endometrial leukocytes brought in by the progestin, altered cytokine production, and let me suggest to you an alteration in either angiotensin or the angiotensin II receptor based on the drospirenone data that I just showed you and on some other studies that I will show you in 2 more slides. If you get rid of the progestin, you can reduce the unscheduled spotting and bleeding. This is conjugated estrogen, medroxyprogesterone acetate, in the green line, showing you the high level of increased bleeding in the first 2 months and then over time getting better. But when you take that same conjugated equine estrogen, Premarin, and you marry it to basidoxifene, shown here, either with 0.625 or 0.45 of conjugated estrogen, you get the same type of unscheduled bleeding as if the woman took a placebo. So 2 estrogens, 2 estrogen receptor agonist antagonists versus an estrogen receptor agonist with a progestin does not cause the bleeding. It is the progestin that is causing the bleeding in these cases. We took Dr. Sri Prasad, who's going to be here presenting some other data this year. We took a look at the Women's Health Initiative database. I had a feeling that women with hypertension bled more in my clinical practice. We found that there was a 37% incidence of hypertension in the continuous estrogen plus progestin arms of the Women's Health Initiative. In the estrogen-only arm, as you remember, they didn't bleed at all. How many of you know why? They all had hysterectomies. They had all had a hysterectomy for unscheduled abnormal heavy menstrual bleeding, I think, as I go back and look at the data, and Roger can correct me if I'm wrong. 36% of these women had their blood pressure controlled sufficiently to prevent stroke or cardiovascular disease, but that meant that something like 64% were not controlled. When we looked at the incidence of unscheduled spotting and bleeding in women with hypertension versus normotension in this group, we found an increased odds ratio of 1.07. That's not a lot. That's typical of the Women's Health Initiative. 1.24, 1.3, so, but it was there and it was significant. If the women were using an antihypertensive medication, the unscheduled bleeding and spotting went up to 1.24. So here are these women who now are saying, not only were we hypertensive, but we were on medication, and we are increasing our risk of unscheduled spotting and bleeding. If they were on an angiotensin II receptor blocker, they reduced it by 50%, an AT2 receptor blocker. If they were on a beta blocker, they also had a statistically significant reduction. There is an entire renin, angiotensin, aldosterone system within the endometrium. There is ACE-converting enzymes. There are angiotensin II receptors within the endometrium. Although they're not yet identified in the endothelial cell, they are around the endothelial cell, either in the stromal cell or surrounding cells. I believe that medroxyprogesterone acetate activates both the progesterone and the glucocorticoid receptor. I think that medroxyprogesterone acetate may act via the angiotensin II receptor that's expressed near these microvessels in the normal endometrium. I believe, based on the data which we're showing with drospirenone through its anti-aldosterone activity, that the hypothesis is that there are alterations in these local angiotensin active areas in the endometrium that are associated with either the glucocorticoid, AT2 receptor, or the mineralocorticoid receptor that are going to reduce the expected bleeding and spotting in these individuals. So let me tell you, perimenopausal heavy menstrual bleeding, I believe medical intervention is the first line. It loses you money. The incidence of hysterectomy in the United States dropped something like 30% over the last 2 years, but the increase in endometrial ablation took care of it all. The use of the progestin increases the unscheduled spotting and bleeding. I have no good treatment for this adverse outcome, short of stopping the medication. I've shown you the data on progestin only. Maybe if they show a pattern that's abnormal, they're going to be like that forever. Postmenopausal spotting and bleeding with hormone therapy is similar to what you see perimenopausal or premenopausal. And overall, I have no effective therapy. But I thank you for listening to this presentation. Thank you.